Yes, and next, I would also like to invite our 5 panel speakers for this discussion. Please put your hands together as I'd like to invite on stage Dr. Lee Hiao Yong, Head of Assurance, Care and Engagement Group, Ministry of Manpower. Let's also welcome on stage Dr. Kelvin Phua, CEO, SATA CommHealth. May we also invite on stage Dr. Marcus Lee, Deputy Medical Director, Fullerton Health. Let's also welcome on stage Dr. Matthias Wee, Head of St. Andrew's Migrant Worker Medical Center. And last but not least, let's welcome on stage Mr. Jeffrey Chua, Head of Mental Health Training and Community Outreach, HealthServe Limited. Now, ladies and gentlemen, once again, you're most welcome to scan the QR code again so that on the back of your badges, you can submit your questions for our panelists later on so they can answer to you accordingly. All right, without further ado, after the golden handshake between our panelists as well as our moderator, I'm going to hand over the stage to Dr. Ho, and it's over to you.
Mic test. Hi, good morning, everyone. Sorry for my voice. I'm down for illness today. So, good morning, everyone. Thanks for being here at the conference with us today, and thanks for all the panelists who have agreed to be here. So, the segment is, like the MC mentioned, is the panel discussion, and the topic for the discussion is we have come so far. So, what is next? And I think everybody will agree that we've done a lot of good for the migrant workers. So, we're here to discuss what we can do more for them. So today we have here from various representatives from the MOM, the anchor operators, as well as HealthServe to share their insights about migrant worker health and the PCP with us. So just a reminder, the back of your badge, there is a QR code called Pigeonhole. So if you have any questions for the panelists, you can post the questions in the live Pigeonhole, and we have a short segment for Q&A at the end of the session. So the MC has already introduced the panelists, so I won't do that. So, and I think Dr. Cheryl has already introduced the PCP, so most people will be aware of what the PCP is. So I won't introduce about the PCP anymore. So I just want to quote some numbers from the news I saw a few days ago about the population. So last I checked the statistics, we have about 430,000 CMP work permit holders in Singapore. All right, so that stands for construction, marine, and process. We have about 390,000 non-CMP work permit holders in Singapore. So that's a really significant population of migrant workers in our community. So earlier when I saw the opening performance, I just got reminded of how I love the multicultural aspect of Singapore. So the migrant workers, they are really a vital part to our nation. They help to build where we are standing, help to build our nation's infrastructure. So I think we really have to take good care of them. So I think we can go back to before the PCP even begins. So my first question will be for Dr. Lee. Right. So how can you share with us how and why the PCP happened? How did the idea begin?
Hello, testing. I think thanks. Good morning. I think this is really a very good conference organized by SATA CommHealth. It's one of the kind, and. I wasn't would be able to hear earlier because there was an MPOX meeting with MOH. I think before, from what I understand from colleagues, is that before the COVID, I think the arrangements for care seeking for migrant workers is rather very much on their own and with the companies. And this issue kind of became a bit more focused when there was the dormitory outbreaks of this COVID-19. And we saw that because of that, the help seeking and health seeking of the migrant workers were a little bit under stress, so much so that they are not very willing to come forward for example, the ART swabs and so on and so forth. And we also realized that a lot of them have mental health issues because their lockdown periods was much longer than the Singaporeans because there's still a lot of ongoing outbreaks in the dorms. And also the mental health also struggled during that period. And we also realized that they are not very regular in their help seeking. For example, they will have their own medications that they will bring from their source countries, and if it runs out, nobody really check on them. So it was this kind of scenario, and a lot of them have gone to HealthServe to seek help, and we thank the doctors and who have been working very hard even to minister to this group of migrant workers. So that was the situation pre-COVID, as I understand to be. And post-COVID, we realized that we need to be a bit more organized and to provide the primary care for our migrant workers. And thanks for a lot of the colleagues stepping forward to help to co-create this ecosystem of the primary care system. And SATA is one of the biggest provider, and they have been doing a good job. And we are quite glad that we are able to serve in this way. Thanks.
So would you say the pandemic, sort of provided a catalyst for the creation of this
yes,
healthcare
surely.
system?
Yeah, indeed.
So my other question was, because they've been a part of our community for so long, so how come there was no primary healthcare system in the past before?
I think that I'm not sure whether there were any specific surveys done, but I do think that certain employers do have arrangements with contracts, employment contracts, and so on. Specifically, how are they covered? I think maybe there were no specific arrangement or organization like what we have had since we started the primary care program. Yeah. So that there are, but it's just that I'm not sure what are the specific gaps at that point in time. Yeah.
Any other comments from the panelists? Okay. So my next question will be for Dr. Kelvin. I'm not sure if Marcus could also want to comment, but so we know SATA is a charitable organization. We've been serving mainly the local community for quite some time. So can you share with us why we decided to go into PCP? Why did we want to start serving the migrant workers? For Dr. Kelvin.
Yep. So I think Chairman has said just now, because we want to care for the vulnerable groups, which are migrant workers. As for what we can do more, I think there are certain areas that we can sort of look into. So I think one of the areas is how the employers themselves will take care of the migrant workers. Yeah. So I think previously it was I'm the company, I take care of this group of migrant workers, make sure that they don't fall sick, make sure they don't cost us too much. But I think moving forward, I think we can have a better conversations with employers as well. So for example, let's say if the report sick for the last month is mainly on back pain, for example, then employers may think that, is there something that I can do to improve the health of these migrant workers in terms of their back pain, or some educational physiotherapy that we can do for this back pain issue, so that they don't, or are they carrying too heavy loads, or are they having the improper techniques for carrying heavy loads. So I think that is one of the areas that we think that they can sort of look into. So that's for employer side. For the migrant worker side, I think we see two areas of needs. I think therapy is one of them, I just mentioned, which we are doing to help alleviate. Then the other area is the dental care, which we have been looking into as well. I think HealthServe and St. Andrew has been doing quite well with their dental services for migrant workers. So these are the two areas that we think that we can sort of move forward in.
So I think SATA, we've got a lot of resources. We can probably do so much more for the migrant workers. So we probably will try to continue to build from what we are doing at the moment. Yeah, so not sure, Marcus, if any comments on why Fullerton started, with PCP.
So as already mentioned, the main catalyst for Fullerton joining the PCP was the pandemic. So I like the topic of this discussion. We have come so far, and indeed, we started from humble beginnings, you see. So during the pandemic, we set up a dormitory medical post. Those were quite rudimentary in design. I remember having to set up a medical, as in I work in a medical post beside a street soccer court or beside a canteen located in the dormitories. But what this allowed Fullerton to do was to continue advancing the needs of the migrant workers beyond the pandemic, because it gave us the chance to see that they do have healthcare needs that need to be addressed, not just individually, but systemically. And it's important to consolidate them, like what we see now, into the various zones, into the various medical centers. So we are not just a medical post anymore. A medical post simply sees the report 6. But as a medical center, with its management team, allied health staff, with its MRO, we can do so much more. One example being public health education. Like we recently had health talks regarding heat injuries. We can have so much more, things like ergonomics and other disease awareness topics as well. Another thing we find that we could value add on a systemic level would be things like infectious diseases tracing. Because on and off, in the dormitories, you may have cases of workers getting a rare disease. Things that, you read about in medical school textbooks but never see in Singapore. Things like pertussis maybe. So we have dealt with cases like that. And with the resources we have available, we can do things like contact tracing. We can do things like prophylaxis, even before the ministry steps in. So this early intervention on our part, I believe, value adds. And this cannot come without the effort of MOM and various agencies to consolidate the healthcare for migrant workers.
Thanks very much for that, Marcus. Okay, so maybe let's move on into the PCP itself. So this question I'll just open up to everybody. We can all agree that the PCP has made a lot of difference to a lot of migrant workers. It has made healthcare a lot more accessible and affordable. I will stress that affordability, right? So in the past, patients may have to pay out of pocket. The bills can be quite shocking. Till now, I still see some patients coming with their receipts of their GP clinics, $80, $100. Even if it's me, I will feel it's expensive, right? So it's made it a lot more affordable. But no healthcare system is perfect. So maybe we can discuss about what's the good and what can be improved. So I'll just throw this out to everyone. What do you think? What's your general view of the PCP, and how has it benefited the migrant worker? Maybe you can start with Matthias.
Good morning, everyone, and thanks for having me on as a panelist. So how has PCP benefited the migrant workers?
What do you think of PCP in general?
Okay, so I think it's a great system that's been set up. As Dr. Lee shared, the healthcare provision for migrant workers were at best sporadic in the past. And this is a concerted effort to ensure that migrant workers have access to affordable and accessible care. So as we know, primary care is very essential. And one of the problems that I saw previously while working in the acute hospitals was migrant workers coming in for early onset of complications related to cardiovascular disease, for example. So young strokes, young AMIs, for example. And a lot of these were contributed by poorly controlled chronic diseases. And one of the barriers was essentially the cost, not just of the consult, but especially the medications. So by having this system where the migrant workers just pay $5 out of pocket with medications inclusive, this ensures that there's firstly better adherence to medications and follow-up. And in lieu of that, they will definitely get better control of their chronic diseases. And so that results in better outcomes for them. I'm not sure if there's any studies done so far to evaluate this, but probably we can consider future research to see the before and after of the implementation of the PCP, how it affects the health outcomes for migrant workers. Yeah, so definitely I think that's one very major thing that has been put in place and very useful for the workers.
Hello. Yeah, I think the PCP has indeed been helpful and beneficial to the migrant community. HealthServe has been in this space for the last 18 years, and we've been anchoring this space about helping the migrant workers in the healthcare. And there's always this long-standing joke that we have that we've just sort of like managed to work ourselves out of job now that we have PCP. Yeah, so we've been attending to the migrant workers who are always hesitant to come forward to have their illnesses treated. In the past, we always know that there's fear about having adverse consequences, like having their work permits cancelled, been sent home because they have some illness or some chronic disease in them. We heard of workers who just come to us secretly without informing their employers just to get medication for themselves. And yes, it was been rightly pointed out that Many of them would get their medication from back home, from their friends who are flying over to Singapore for work, and they will just medicate themselves accordingly, and there's no real proper control of how well their diabetes or their chronic disease is happening, being handled. So yeah, it is indeed a blessing in disguise that COVID-19 sort of like uncovered some of these issues and brought to the attention of our Singapore government and to establish this PCP for the good of the migrant workers.
Till now, it still happens when I see patients. They still tell me that they are buying the medications from overseas. They're still self-medicating because they can just easily buy it, back in India. Yeah, so I think it's good that now they have a place to come where they really can, be followed up properly for their, especially their chronic conditions.
I think we have to address what's next. I think we have done quite well.
Maybe for the what's next, maybe I'll come to that in a while.
You're coming too. I thought we were finishing.
Yeah. We'll come to that in a while. So I'm going to throw that question to you later, Dr. Lim. But yeah. So any other comments from the rest? Okay. If not, maybe you can just share with us, what are your challenges every day when, working with the migrant workers, either as a clinician personally or as, operationally as a whole from a clinic's perspective? What are your challenges? You want to take that, Marcus or Matthias?
So one challenge, I think everyone would agree, would be the language barrier. Because, there are workers of many different ethnicities and language groups. Even if you can speak the more common ones, such as Hindi or Tamil, right? There are 500 over languages in India, several more in maybe Bangladesh and other parts of the world. You may not have interpreters to speak the exact dialect. So sometimes that definitely is a challenge. What our clinicians may have to resort to is Google Translate. But as you know, that isn't 100% infallible as well. So these are one of the challenges. Another one would be, I think, a point that was brought up just now, the point of overseas medications. So some of the workers may come over with, medications from overseas because it's cheaper, it's a trusted brand. But sometimes we may not have the equivalent in Singapore. You see, it comes with an interesting combination, maybe metformin and pioglitazone or something like that. Formulations that we don't really see in the Singapore pharmacy. So medication reconciliation is another one. And last but not least is also the past medical history. So just to share, Fullerton also runs the onboarding center, the onboard center where we triage all the migrant workers who come into Singapore. Yes, we do make an effort to ask their past medical history, any previous surgeries, any long-term medication. But sometimes these can be hard to elicit as well. So admittedly, there may be workers who fall through the cracks with medical history that we may not be very familiar with. They do not come with their memos. They do not have the adequate knowledge of their condition. So these are the challenges that the clinicians on the ground have to deal with. So I'm not sure if anyone has anything else to add with regards to that.
Maybe I can just add for just the previous point on language barriers. I think one thing that we find difficult is definitely communication, but one is understanding. So the patients tend to be very eager to please, whether it's the employers or in the healthcare setting would be the healthcare provider that's seeing them. So they would frequently nod their head to show that they understand and they will comply the medications and so on, but they actually do not sometimes they do not understand anything at all or just in part. So one of the issues would be how do we ensure that the patients follow through with the management plan, which we think we've done a great job in explaining, but there's no translation at all. So what I often tell my team members in my clinic is you have to see the light in their eyes. There's a light of recognition that they understand what you're saying, and of course, reading back is the other thing. If they're able to read back and tell you what exactly you've told them in their own words, and you show they understand, that's fine. I think another factor would be cultural barriers. So I'm not sure if it's just unique to migrant workers from India or Bangladesh, which is the majority of the population that we see in my clinic. But sometimes the idea of adhering to appointments, follow-up, is completely a foreign concept. So what they do is they only turn up when they run out of medications, and they will default the appointments. And of course, that means you have a period of a couple of weeks or days to weeks or even months of poorly controlled chronic diseases, and that's definitely not beneficial to their health. Another would be medications. So the idea of taking so-called Western medications, I would say it's not unique to that population. We also see that in Singapore as well, among the local population, taking traditional supplements or special kinds of treatment. I had a patient recently that was told by his doctor to go back for some alternative treatment when he could have easily received the same kind of care in Singapore. So these are some of the things that we do face, cultural barriers as well. Yeah, thank you.
I think to add on, trust is also one thing that we have to gain from the migrant workers. I know when PCP first started, we still had a lot of migrant workers coming to us. So we always have to turn them away, say, brother, please, you got PCP, please go to your PCP clinic. They were very hesitant about government-initiated programs, things like that, where the trust level was low based on their own familial background experiences. So we had to help to instill or help to grow that trust, tell them that, brother, these are good doctors, they're going to help you, they're going to see you. So that was something which we had to navigate at the start of the PCP implementation. It's good also that the clinics, a lot of the clinics are located in places that are much closer to the migrant workers. As you know, they are housed in dormitories which are like in Tuas, in Kranji, areas that are quite inaccessible by public transport. So it is good that we have these medical centers that are nearer to them and gives them easier access.
So just to add on about what Matthias mentioned about cultural barriers, I think the way the patients interpret the symptoms and how they convey the symptoms also depends on their culture and when they are from, right? So even till now, I still struggle to interpret some of the patient's symptoms. Right? Like most of the workers will say they have gastric, like almost all of them, I would say. So what does that exactly mean, right? So it's really hard for us when we have such short amount of time to really try to see what's actually real and what they think the problem is. Yeah, so it's not easy.
Yeah, so just to add, I think one of the issues is the fluctuation in the migrant worker report sick rates, the load. So it varies. So sometimes the clinic may not be able to handle the fluctuations in the report sick. So for example, Mondays is usually very crowded and waiting time can get a bit long. So we did study that, and then we say that, okay, maybe we should study the polyclinic load. So we found a correlation between the polyclinic ARI load and the report sick rates in the migrant worker centers as well. So we also studied other factors. So for example, if there's a cricket match between India and Pakistan, is there going to be a high report sick rate the next day? Actually, there wasn't, actually. We studied that. Yeah, so paydays, okay, after a payday, I think they go out and celebrate. So the next day, maybe more report sick. So we try to study those trends as well. Yeah, so the fluctuation in the report sick rates, as well as the manpower able to cope with this at the various medical centers. So the other challenge that we have is the social factors that which we have a little control of. So we take care of the healthcare, but I think sometimes the social determinants of care. So for example, if the migrant worker is in debt, or he may go into depression, or you have problems with the family back homes, they can become very upset. So I think that part we have little to help them. I think HealthServe has very good counseling services that we do tap on. Yeah, so these are the few challenges that we have.
So I will get Mr. Jeffrey to show us, some of these things later that do the good stuff that they've done. But we've got a question up there on the screen. The work that's been done is amazing so far. Just wondering how these efforts are sustained financially, and is it possible to be self-sustaining? And what happens when current government subsidy runs out, I guess? Ends, yeah. Not sure if Dr. Lee wants to answer that question.
I think just to correct some kind of misconception, actually there's no government subsidy for this system. The employer themselves pay for their migrant worker per capita, depends on who is the provider per year. I think the range is between $108 to $138, if I'm not wrong. So actually, there's no government subsidy. So it's quite amazing that this work is ongoing. So that's the first. I think second is actually, I think our migrant workers they come here to work, and so their report sick rate, thankfully, it's not like wantonly high in a sense, meaning to say that people just want to go and take an MC. So I think we are we monitor this very carefully, and I think it's not high in the sense not so much that they are not aware, but I think they want to work hard, and they really reporting sick is really out of necessity. And I think this is something also it's a double-edged thing, because they may work over hard work, and then they may hide symptoms and injuries and so on and so forth that's under-detected, and then they only manifest when it's very serious. So I think to answer this question, I think we are reviewing it on a periodic basis at a government level. I think that there's a term of contract with our providers, and when that is up for renewal, we will definitely have to review together with our providers what's the best scope of service and so on. So that's a long answer to a very difficult question. Yeah.
Okay, any other comments? Okay, so my next few questions are for Jeffrey, who is from HealthServe. Okay, so maybe just a quick introduction about HealthServe. HealthServe is a charitable organization founded in 2006. So they've been serving the migrant worker community for quite some time now. So they provide not only medical and dental services, they also provide casework and social services, mental health counseling, and outreach programs. Right. So I think, personally, I think primary healthcare, we can't, it's not only just about, treating the disease, treating the blood pressure, the hypertension, or the flu-like symptoms. But we also have to look at a person or a migrant worker from a biopsychosocial, point of view, right? So, like Dr. Kelvin mentioned, there's also the social determinant of health. We also have to make sure, they're happy. We have to, look after their mental well-being as well. So we know that migrant workers, they are a fairly vulnerable group of patients, and their social circumstance may be quite different to, a local resident, because where they're from is very different, right? So I just want to ask, what's the kind of clients of cases you have seen for patients for workers who require casework or social assistance?
I think most of the time we would support workers who have suffered work injuries. Mm-hmm. So some employers may not, they try to push away their responsibility. So that's where we will try to bring in whatever is necessary and whatever is mandated by law to make sure that they get the proper care and support minimally. I suppose one of the biggest social concerns for the migrant workers is that the most basic, or for all of them, they do not have their family here. Whereas with Singaporeans, all of us are family. So that isolation and distance from family can be very disturbing to them. And at HealthServe, what we try to do is we try to be their family to them. I think that's very important to many of the migrant workers. They feel that they are welcome. They feel that they are being helped. So those workers who have got work injuries or salary disputes in their course of work, they feel abandoned, and so we will come in and try and support them in whatever is mandated by law. And then if we have the support and the funds and resources, we will support in some other areas, like giving them groceries, giving them meals to sustain them through meeting their basic needs for the time being.
Mm. So does HealthServe actually mediate, these processes between the workers and the employers, or the legal processes?
We don't deal directly with the legal processes, but anything that is by law a requirement from MOM, we will always point them back to where to get the help from. We always believe in wanting to empower them. We are not there to feed them and carry them throughout the whole situation, but allowing them to rise up as individuals, that they know their rights, they know their possibilities of where to get help, and that they will be, I wouldn't say bold, but at least be able to stand up to the employer and say, look, I'm supposed to get the proper health care. Why are you not providing it for me? So that they will then I guess, giving them dignity for who they are.
I'm not sure if St. Andrew or Fullerton does provide such kind of assistance for the workers.
So St. Andrews provides counseling and case management. And what we have is that, so what happens is that sometimes workers have certain disputes with their employers or so on that require case management services. And so therefore we have a counselor who is also trained in case management to handle such situations. There are actually a lot of bodies, a lot of different organizations that are already poised to help patients, particularly for case management aspects. One big player would be definitely MOM. So we try to get the patients directed to the various sources where they can get help. The other one would be counseling. So there is a significant mental health burden on migrant workers. I would say maybe not so much in terms of actual diagnosis of a mental health condition like depression or anxiety following the DSM criteria, for example, but they are just general stresses or mood-related problems and often contributed by many of the social or economic factors. So we have a counselor that does help them, and if necessary, we do refer patients on if they require medications. Most of the time, by and large, these cases can be managed with counseling and follow-up sessions, and so we find that helps the migrant workers.
So just to share, in Fullerton, we do not have an in-house counselor per se, but what we do have is a workflow for mental health for us to triage the workers accordingly. So we use adjuncts such as the PHQ2 system or the PHQ9 system to identify workers who may be at risk, and then we refer accordingly. And we have also been working with HealthServe with regards to that. As mentioned, some of the workers may not have clinical depression or anxiety. They just may need a listening ear, a shoulder to lean on, and for that, a counseling service would be more appropriate for them. And just another note about the adjuncts that we use, the PHQ2, PHQ9 scoring systems. We make it known to our clinicians that this is not the be-all, end-all. Eventually, it's not just a numerical value. And if you see if you have the clinical discretion to escalate care as necessary, by all means, we need to do it as well.
Maybe to add on, I think it is right that the mental health of the migrant workers is not much different from what Singaporeans are also facing right now, and there's so much awareness and coming to light, making it as destigmatizing mental health. So I think in working closely with MOM, that's how HealthServe has also started the 24-hour helpline, where migrant workers, not just migrant workers, but people who work with migrant workers, who know of migrant workers with slight mental illness, or rather just feeling depressed, feeling anxious about their situation, they are most welcome to call our helpline and get support. We have native speakers to assist them and just be that listening ear to them.
So since you're on topic of mental health, I thought I'd just talk a little bit more about this and maybe to create a bit more awareness of mental health issues in the migrant worker community. So I think HealthServe has been in this space for quite some time. Maybe Jeffrey can tell us a bit more. I think we have a plenary session on mental health in migrant workers later on, but we probably can learn a lot from HealthServe. I'm just wondering if you could tell us, what are some of the most common mental health issues that they face. Personally, I don't really see that much mental health cases in my own practice. Maybe they don't come to us. I'm not sure. Yeah, maybe we want to shed some light on this topic.
Through our experience, I think maybe about 1 in 10 of the calls or the workers that we encounter would have a bit of mental health challenges. I wouldn't say issues per se, but it's a problem. Is always a crisis to the migrant worker, because being at the very bottom end of the so-called hierarchy, where they're doing all the menial jobs, they're very afraid of losing their jobs, having to be sent home when they already have a debt here in Singapore. So money is definitely one of their concerns. Holding on to the job is the next concern. And then other problems that stem up when their family calls them, the daughter is sick, the son is sick, or the mother is not well. So these are all problems that will be triggering to them. It is not saying that it will lead them to a mental health issue, but again, having someone to be able to engage with them, to talk to them, to help them understand their situation and support them, speaks volumes to them. So yeah, these are just some of the issues that migrant workers would face. Yeah.
I mean, I think after, I've been working with them for 2 years now, so I think sometimes you just need to be a bit more reassuring, right? Often I get these workers come in and say, they've got back pain, and it's probably just a muscular problem, but they will come and tell me, oh, I'm very scared already, right? What happens if, I've got some kidney problems and I can't work anymore? So I think that's always their worry, right? They can't work, they can't provide for their family. So it might be things as simple as that, but sometimes we just need to be reassuring, right? Tell them it's fine, you're fine. So we've got another questions up on the screen. What's the coverage like beyond primary care service? For example, if worker is referred to secondary or tertiary hospital?
Yeah, maybe you have to ask MOM.
I think we do see the secondary care as well as the hospitalized workers. I think you read in the news, those workplace injury, often they are the migrant workers. And they get hospitalized. If you go to any ED, there'll be walk-ins and so on. So the answer is the employers have to pay for those specialist consult. And that there lies, I think we understand that the issue. There are progressive employers who are very enlightened, because they know the health of the migrant worker will be a health for the industry, for their company. But there are those who, will count beans, and then you need. I have spoken to hospital colleagues that they have to, really call them many times to just get the letter of guarantee before the payment is made and all sorts of things. So there are gaps there, and the employer's responsibility is there, but it's just that maybe there are some of them that needs a lot more awareness, a lot more encouragement to say that, you really, under the law, the Employment of Foreign Workers Act, there's a duty for you to provide for medical care for your migrant workers, for your foreign workers. I think under hospitalization is a little bit, I wouldn't say easier, but it's a little bit more specific. There are insurance that they have to pay, I think 60,000. So that's kind of covered, because I think any hospitalized cases will usually attract a larger hospital bill, and that part is kind of a bit covered. But even so, it can also, there are cases who you need multiple procedures and all, it will bust that 60,000 limits. So this is a work in progress. So when we review the whole primary care system, all these areas are issues that we have to also address. Not so much that we will have a solution overnight, but I think every party will have to come on board and recognize that this is an ecosystem kind of approach. The employer's responsibility, as well as the migrant workers themselves, as well as the providers themselves. Yeah.
So I'm just curious, Jeffrey, are your mental health counseling services usually overwhelmed? Or do you think there's a need for more of such service?
I think the work is never easy. We are relying on two staffed counselors, one that speaks Tamil and a few other Indian languages, and another one that speaks Bengali. And then we have some volunteers, interns, and volunteer counselors who support in the other language tracks. It is not easy because in addition to the one-on-one counseling, we also run sort of grief support for workers who have experienced sudden death or suicides of their co-workers. And that is something that is quite important as well, because we often forget that there are people affected when they witness a death of a friend or co-worker, and it can hit them quite hard. So we will come in to support and see whether additional counseling is required after that session. So yes, there's really no end to the amount of counseling sessions that our counsellors have to support. Some workers, we've had workers who needed counselling for. We lost count of how many sessions we've provided, but it's been ongoing like for half a year or even longer. Yeah.
So I think that's one thing we're not really doing at SATA. That's probably one thing we can look at. Maybe we can collaborate in the future.
Hi, Chin Sui.
Yeah.
Hi.
Hey, hi,
Sorry,
Natalina.
hi. Sorry, just to interject and probably take some points from the previous questions. I'm not asking a question, actually. I'm commenting on the question regarding the government subsidies. Yes, it's true that the government does not subsidize this primary care plan. I'm from the MOM, by the way, medical policy. But it's because the obligations for the employers to maintain the medical costs is embedded into law. It's not because the Singapore government is so cruel, they built our infrastructure and we're not giving anything back. But it's a law that has been in place so that the employers understand the true costs of getting foreign labor. So that explains why there's no subsidy. The system is self-sustaining because we went with a capitation plan. And capitation plan is risk-pooled. We are very fortunate that our migrant workers belong in the age group between 18 to 50 and they are well. There's a healthy worker effect because prior to coming to Singapore, there's already some self-selection that goes on. The fit, the ones who can do manual labor, the ones who can pass the medical examinations get to stay here and work. And that's the way it should be. To subsidize such a system, it invites the local foreign parity optics, But in any case, the capitation plan seems to work. It's quite novel. It's akin to Healthier SG, but we rolled it out even earlier than Healthier SG. So that's just to answer that particular question. Thank you.
Thank you. Okay, so next question. The PCP clinics do not cover dental care. They are only advised to visit dentists or given painkillers as a temporary measure. Is there any plan to have dental service to the clinics?
Yeah, so I think HealthServe and St. Andrew does provide dental services, but it's not part of the PCP plan. Doing good job, I think, but then the migrant workers may have to travel a bit further to reach them. So we're exploring some dental services in the north as well. I think that's a work in progress. Yeah.
Yeah, so we are not neglecting the dental services for the dental needs of our migrant workers. So as mentioned, there are available chairs, and we thank I think Migrant Well, who Singapore, who actually donated the chairs, and as well as we work quite closely with the Chief Dental Officer at MOH to make sure that there are rotational dental residents to come to these centers to offer the service. And there are also dentists that are hired to do that work. But of course, it's not enough. Hence, we need to, like what this conference is about, to innovate for migrant workers. So we have actually done a survey, what we call the oral health survey. It's something that we co-developed with the Chief Dental Officer Office in MOH, together with NUS, at NUCOT, National University Center for Oral Health, to come up with an instrument, oral survey, that we can depend on non-dental professionals to help to do that survey. So I think it's going to be much more implementable, scalable, as well as meeting the needs of triage, so that not all cases will come and flood the St. Andrew and as well as migrant, as well as health services, but there is a process of triage so that the ones that need the dental service can be channeled and referred appropriately for the care. So this is still work in progress. Like what Kelvin was mentioning, we are trying to work with SATA, see whether there is an opportunity. But it's not easy because the chair is expensive. You need to have a site, you need to have manpower, you need to think of all this, and have to make it sustainable.
Thank you. So, okay, this question is for Dr. Lee. So, how have we met MOM's expectations so far? Also, we've got another question up there. Sorry, as employers are liable for all medical bills incurred by their foreign employees, there are malicious foreigners who enter the country on forced employment to seek treatment. How can it be detected?
Yeah, so we passed the difficult question. No, we'll try to answer.
I think MOM is quite a large government organization, so we have different departments to deal with the employers, employees, and so on and so forth. So if you have some information, please tell us. We will certainly take it up and investigate.
Okay. Okay, so just for Dr. Lee, so have we met your expectations so far, PCP anchor providers? How do you think we've done?
Difficult question. Of course, I think it's not only just my view, but I think we also have polled the migrant workers themselves, employers. I think we've worked with the tripartite TACs, the trade association, from the marine, construction, and all the employers fed back that it's a very good system. So it's not just based on me, and we've spoken to also our NGO colleagues and partners. They also feel that this is really a right direction. But of course, as we have been discussing, there's a lot more that we can do, and we can do better together, as well as to innovate. Because often we just think of buying something, some technology or whatever it is, but we have to think of how to do it sustainably. Because at the end of the day, it's quite a large number of them, and we also need to support them with evidence-based science and care protocols. So I think the answer is yes. I think everybody has done well. I think we have been monitoring as well, and also have been a lot of collaborations to feedback on how to improve the gaps. Of course, there are a lot more things to improve on, but overall, I think it's a resounding yes.
So I've just got one more question for you. Okay, so this is, okay, so personally I see, a growing number of migrant workers with chronic diseases, and they may already have these pre-existing conditions before they come to Singapore, and they didn't know about it, and they were picked up on, during their medical examination when they come to Singapore. So do you think if there's any role in pre-screening these patients before they come to Singapore? Because we know chronic diseases increases, healthcare cost and burden.
Yeah, so we don't reject migrant workers with diabetes or hypertension. I think the key thing is that there are specific ones, infectious diseases that under MOH, Infectious Disease Act and so on, that there are specific ones. But then, generally speaking, as long as they can work and employers have got them in and they pass the medical examinations, we do have to work with them when they are here. The whole primary care system is also sort of shaped to manage chronic disease, even though the medication is not the very high-end ones, but it's the same adopted for the subsidized drug lists that MOH uses, so it's nothing inferior. So I think we do have mechanisms to take care of them, and some of them do develop risk factors and chronic disease risk factors as they work here, maybe because of the stress of I don't want to say the food they eat here, but the way they work and so on and so forth. There are risk factors of chronic disease that actually is inherent in the way they work and the way they have been working. So I think it's not so much about a screening, but more about an overall chronic disease management program that we need to come to terms with. The whole world is aging, so increasingly you're going to get Indian and Bangladeshi workers who are a little bit older, and some of these older workers are the ones that the employers want because they're technically more savvy, they are more skilled, and we have to look at this holistically.
Okay, so my next question is, we've come so far, so what's next? So maybe I throw it out to all the anchor operators, to throw out your wish list for the next step in PCP. What do you think? What more could be done for the migrant workers? What do you want to see for the next PCP?
Okay, so I think we spare Dr. Lee first. Take some pressure off him. So, Christmas come early. What is on our wish list for the PCP 2.0? As we formulate these wish lists, I think we also need to be pragmatic. I mean, it's not just a wish list that we want. We need to think of ways that we can achieve these wish lists also. And one of the more pragmatic things would be to be able to handle things more on an organizational level, right? So far we have been engaging the employees, but what about the employers? So I did mention just now, we have been giving some health talks on topics such as heat injuries, haze, and so on. We have been making attempts with the employers to show that we can do more than just like seeing report sick or chronic diseases. We offered things like statutory medical examinations also. We can even offer a fitness to return to work if they are willing to come on board. So this engagement process is still ongoing. The sense on the ground is that I think many of them have their own medical service providers with regards to these medical examinations really. But we have been trying to float the idea to them, why not? This medical center can also be an examination center to provide more occupational health related services.
Maybe just to share my point of view about engaging employers. I think what is very crucial is for employers to see that their workers are not just numbers, but they are people with families that care for them and people have hopes and aspirations. So looking after your employees will naturally result in employees who are willing to work harder for you, do more than their job scope. And I think eventually, if that occurs, that can lead actually to a better outcomes for the companies that employ foreign workers. I think though there are many companies that do look out for the well-being of their workers, there are still the bad apples out there that frequently get into case management issues because of practices that are subpar. Yeah, so that's one. How do we engage employers to get their buy-in to the welfare of their workers? I think another one would be what I like to term as a last mile. So we have a lot of things that are done for the workers, but can they reach them? There's an app that they have that actually is really well done. A lot of information is in there, but do the workers know how to use it? Can they even log in? They first learn how to use the app when they first come for onboarding, but months later and years later, they have no idea how to use the app anymore. And that app contains information that is so useful for many reasons. It can just be ease of registering patients with accurate contact information. It can be knowing which zone the patient is for their PCP. But sometimes we face problems where we cannot identify all these or cannot find such information because there's no easy central way to get this information. Another one would be what I would term operational. So now we have different anchor operators across 6 zones, and each have their own pricing for PCP, and each have their own management of the PCP itself. However, this obviously leads to difficulties among the employers who have to navigate multiple different systems. So I think one wish list would be if it can be done centrally. And of course, naturally, I think that would be something that MOM would consider, we hope MOM would consider at least, to manage all these centrally so that there is a seamless way of transferring between zones or just one-stop portal for employers to visit so that they know where to find information and what to do from there. Yeah, these are just some thoughts I have. Thank you.
Dr. Kelvin, anything?
Yeah, so I think we've talked about the employers, we talked about how we can get them to be stewards of their own health. I think that's one of the things that we really want to aim for. Increase health literacy, increase better health-seeking behavior, and of course the general well-being of the migrant workers is really important. So in HSG we have social prescribing. I don't know whether migrant workers have this similar kind of concept. So when we invited them for this walkathon, I think they came for the SATA walkathon, and when there was this activity, this event called the Sea Regatta, dragon boat racing, and the migrant workers were very sporting, and they actually had their own team. So I think all these activities will help improve their well-being. and make them become more motivated to be healthy.
Yeah, I think we'll be doing some of those review and taking in all these suggestions. This current PCP actually was developed very fast lah. I think in the midst of pandemic, and it has to come out quite fast. So I think with that kind of speed, with that kind of shortness of time, I think I must say that it's done well. The thing is that how to improve, like everybody's saying. In terms of employer engagement, we are already planning something next year to reach Singapore HR Institute and so on and so forth to better communicate back what I think all of us are seeing. Sometimes the HR practitioners may not see the same, so we need to actually, a lot of awareness and communication is needed. So in terms of operation, I think we are also thinking through how to better synergize, because currently we have to divide by zones. That was again a design feature of the current system, but going forward, is there a need to shift some of the design? Because actually we have more workers now compared to before or during the time when this system was envisaged. I think we have a lot of workers, like for example, we're building T5, there's a lot of dormitories there. They are kind of a little bit underserved, so we have to think about how to strategize even before we come to the end of this term of the contracts with the current providers. So it's work in progress. What's next? I think we need your views, not just the anchor operators, but our colleagues in NGOs and all. They have very good ideas, like HealthServe. They've been dealing with workers for a long time, so that we know that these are good feedback that we have to listen and have to adjust our system to meet the needs. I think one that a bit closer to my work is actually what was mentioned is actually the climate change related measures. I think a lot of the migrant workers are working in the sun. We have aircon to run to, but you can't dig a drain and then go to the aircon, then dig the drain, go to the aircon. This doesn't happen like that. So how do we protect them? So these are measures that at the national level we can come up with a lot of stipulations. Companies can comply, but at the end of the day, I think we need to watch out for them. We need to have surveillance system. We need our providers to have that education, that extra time that somebody was, it was Matthias was mentioning, the extra time, just a listening ear to assure, and also to detect, whether there are heat injuries and so on and so forth. So I think we need to work together. There's a lot more challenges coming forward, whether this primary care system can really help, and like there are questions on secondary care again, attending to ED, whether the employers will be aware to pay and all sorts. We have to think quite broadly. Yeah.
Okay. So, just personally, I feel that other than just PCP, other than just treating the different diseases, I think there's probably a need to emphasis on the preventive aspect of health, right? So I'm a strong believer of if you want to be healthy, you have to eat well, sleep well, work well, and be happy. So I also believe in this you are what you eat, right? So very often I see workers, their meals are very imbalanced, right? Just a mountain of rice, no nutrition. So it doesn't help if the patient's got diabetes, right? So we also have to think about all these things that can contribute to a person's health. So we've got a question from Dr. Arvind.
Well, not really a question. I just thought I'd share a couple of thoughts on two small points which I heard in the discussion. One is, I think, Dr. Chin Swee's observation about appointments and how migrant workers many times do not they come only when their medications are over or there is a need, and they don't honor the appointment. So we have a system of, we run geriatric clinics in rural areas around my institution. And every 4 weeks is the clinic at one particular location. And we encourage people with chronic disease, older people with chronic disease, to come once in 4 weeks so that we can review their condition and continue. But when we face this problem of people not coming on the time they're supposed to come, but coming only later, what we did was to offer a small incentive in the form of an additional small discount on the medication for people who came at the 4th week, as compared to those who did not come on time. So that's just an incentivization of people to come according to their appointment. It's just a thought that I thought I'd share. The second thought that I'm sharing, like I said, we have this huge outpatient that we have every day in our hospital. And every month we have our new joinees. And some of us have to speak to them every month as an orientation program. And I tell them one thing, which is that when these 2,500 outpatients come every day, they're looking for two things, in my belief. One is they're looking for competence to solve the problem with which they come. But the other is they're looking for kindness. And I heard the word mentioned in different ways. One is, I think, one of the gentlemen here mentioned, when you speak to them, you see a light in their eyes when they understand what you're saying. And the second was reassurance is another thing that they need. But I think we're talking about the way in which we approach our client. And I think that I cannot overemphasize what you gentlemen are saying, which is that kindness in the way in which we approach our patients will definitely make a difference to a worker who's come from another geography and is seeing somebody whom he's not used to seeing. Thank you.
Thanks, Dr. Arvind. Okay, so this is just a last question for, again, Dr. Lee. Can you shed some light into what's, the plans for PCP moving forward? Anything at all?
We are already starting to engage the Ministry of Health and as well as colleagues here to think of how to design it, as I mentioned, organizationally, how to organize it better, because there are pockets of migrant workers that are not covered. Just because the job have shifted, we decided to restart the T5, for example. The dorms were just closer to the work site and T5 and so on. So these are some immediate things that we may be doing. Then the other thing is about, the portability, whether or not we can make it less, because currently you need to, enroll in one and then re-enroll. So we know those operational concerns and frustrations. So those are the things that we are trying to look at immediately. The other areas are the areas that you mentioned, the preventive medicine, preventive health, dental. Mental health, I think we have a little bit of runway. I think we want to make it a little bit more embedded as a system, not so much through a therapist, through a psychologist, because we don't have those resources. How do we do that better? And like the Healthier SG part, I think same preventive. We are looking at see whether musculoskeletal is an area that we want to further work on, because we know from surveys that a lot of them come in and say it's painful, backache. We think that it could be repetitive strains and other kind of conditions that maybe maybe cumulative work injuries or whatever, that we need to work from an occupational medicine perspective, together with employers as well as workplaces, to see whether to improve those areas. So these are some of the work in progress.
Okay, thanks very much. Any other questions for? No. Okay, so thanks very much once more to all our panelists for sharing their insights.
Thank you very much indeed to our moderator, Dr. Ho, as well as our panelists for such an insightful panel's discussion. At this point in time, I'd like to invite Dr. Ho to present a token of appreciation to our 4 guest panel speakers. So can we bring on? No? Sorry, it's Dr. Kelvin Phua to come on stage. So we're going to present to Dr. Lee Hiao Yong. Thank you very much. Head of Assurance, Care and Engagement Group, Ministry of Manpower. And we also like to present to Dr. Marcus Lee, Deputy Medical Director, Fullerton Health. And we'd like to present to Dr. Matthias Wee, Head of St. Andrew's Migrant Worker Medical Center, and Mr. Jeffrey Chua, Head of Mental Health Training and Community Outreach at HealthServe Limited. Thank you very much, gentlemen. Now, ladies and gentlemen, actually through the QR code we receive many questions, but due to time constraint we are unable to answer everyone right here. So what you can do is please feel free to write in to clinicalservice@sata.com.sg. So we will actually answer to you from there. It's clinical services, actually with the S, at sata.com.sg. Once again, a big round of applause. Thank you very much, gentlemen. That was great. Now, my next announcement must be one of your favorites as well, because soon we will be having our buffet lunch break sponsored by Modana. So kindly help yourself at the buffet at the Kallang Room, as well as along the